Welcome back, everybody. We are starting the early career researchers presentation, and hang on to your hats because it's going to go fast. So each presenter have 3 minutes to present, and I keep the clock running. And then we have 2 minutes to ask questions. So I ask you to think quickly about your questions because we don't have that much time to wait for your questions. So prepare them as we go along. Yes. And the first speaker is Bethan Reeves.
Hello. Can you hear me?
Yes.
Yes. Fantastic. I am Bethan. I'm a population health data scientist at Merseycare NHS Trust. And in my free time, I'm also a professional doctorate data science student at the University of East London. Over the past 15 months or so, I've been specifically supporting the Life Rooms, which is a community-based service offering social prescribing and learning and inclusion support. Predominantly, this piece of work is an exploratory piece to be developed further by the service. I've no doubt that each of you has been recommended a product or two when you've been shopping online. Or perhaps when you've been in the supermarket, you might have noticed that nappies are near the beer in the same way that sugar is near the eggs. From kind of a rudimentary level, this type of marketing branches from basket analysis or association rule mining. And this explores which products individuals buy together and the strengths of links between these. We've applied the a priori algorithm to the Life Room service base to understand why people are seeking support and how often these reasons commonly co-occur. So you can see there on the left that reasons for attending the Life Rooms were split into 14 categories, and more often than not, individuals will kind of cite multiple of these reasons for coming to the service. The animation here is showing the graph resulting from the rules that have been generated from the analysis. What we learn here is that kind of on the peripheral we have COVID-19 support and advice and advocacy, but as you see there, mental health and wellbeing sits at the centre of the service. So some of the kind of more prominent association rules are at the bottom here. So for example, individuals who need help with housing, or they're interested in Life Rooms learning, or they fall into kind of the other category, are 2.7 times more likely than a random service user to also be interested in financial advice and support. And we're 82.4% confident that there's a link between these services. So kind of the end goal for this piece of work is to implement it at the Life Rooms so that we can advise new registrants of additional services or support that they may be interested in based on the items that they come to us with. Through the kind of iterative process of assessing those expressed needs and the recommended provisions and then service engagement, hopefully we can offer our service users a complete package of support from their very first visit. Implementation at the Life Rooms is going to take some time, but we hope to bring this through and ultimately produce sustainable models in care at the service and offer our service users a holistic pathway to both prevention and recovery.
Fantastic. Thank you. Thank you so much. Questions? You probably kind of mentioned that at the beginning, but I was still kind of fiddling around with my paper. Can you just remind us who are the typical users of such?
Yes, so the Life Rooms supports people across Liverpool and Sefton, and it is anybody. Anybody can walk through the door, or they may be referred by their GP or community mental health team. But if you want help with housing or finance or benefits, if you're struggling with your mental health or physical health, you can go to the Life Rooms, you can turn up, you can register and say, what can I do? What do you offer? The Life Rooms themselves will offer internal interventions through their social prescribing, but also they'll help put you in touch with external.
Yeah. It's clear that the Life Room kind of provide or generate lots of data.
Oh, yes.
So do you know who would be the typical users of the data?
Yes, so a lot of A lot of our service users, I suppose, identify as female and around 45 years old. We are trying to target more a younger demographic because there's initial evidence suggests they respond best to this forms of support. But yes, typically at the moment we're looking at kind of 45, 55-year-olds.
Great. Another question. Yes, Ben.
I was curious, do you collect demographic data? It sounds like you do collect demographic data. Have you looked at whether the network that's generated for the service users differs when you sort of disaggregate by age, gender, anything like that?
So this is slightly complicated in that the data collected by the life rooms is one set that we have, and individuals are mixed in whether they provide their demographic information. However, we do now have more of a linkage into what is known as the CIPHER dataset, which is the Combined Intelligence for Population Health Action dataset. So this is across Cheshire and Merseyside and links to primary care data, MHSDS, CSDS, emergency care data. From this, we can start linking in to bring in more accurate demographics. But at the moment, we're looking at about 50% because we can only link using NHS number. And when if an individual walks off on the street, they probably won't know their NHS number when they register with the life rooms. So once we've got some more complete data, yes, that's definitely a way we will go with this work.
Great. Thank you so much.
Thank you.
There you go. The next speaker is Ella Cristoforo. Forou. From Swansea.
So, hi, I'm Ella, and I'm currently doing a PhD, but I'm just going to talk about some work I did in SAIL, so the Secure Anonymised Information Linkage Data Bank, that's just over there if you don't know what it is. So, the project I was doing, we kind of were looking at that the number of people with severe mental disorders, has increased. We've kind of spoken about this before. Mental disorders as a whole have increased, particularly since COVID. And, these people often have, reduced health and reduced life expectancy up to 10 to 20 years compared to the general population, which is massive. So, it's really important we're looking into why this could be the case. So the aim of my project was to describe the socio-demographic and environmental differences between the general population and people with schizophrenia or other psychotic disorders. So anonymised records for individuals living in Wales between 2016 and 2019 were linked with air pollution in the SAIL data bank. And then in this population, individuals with their first diagnosis of these disorders were identified. So we're kind of looking at onset in this period. And then we looked at the distribution of these disorders in terms of age, sex, city, like urban or rural location where they lived, and then deprivation and also their air pollution exposure, so if they're living in more polluted areas or not more polluted areas. So this is just showing kind of how it was linked. It's just a very simple diagram, but then the environmental exposures, that air pollution I was talking about, and then where they're living. This is the Welsh Demographic Service data set. WIMD is deprivation one, and then this is the GP. Then they were all linked together. So in terms of the population, there was only 0.1% of the whole population that were identified who had the onset of schizophrenia or psychotic disorders in the 2016 to 2019 period. So it's a really small number. And then air pollution and the percent in urban and rural areas was quite similar in both cohorts, which we weren't expecting in the mental health cohort and the people without mental health. But we did find that there was almost double the number of people with these disorders in the most deprived areas. So that's here, and then this is the least deprived areas. So it was, a lot less people. So yeah, in terms of, this was just a small little study I did in, to go on towards my PhD. So my PhD is looking at the effects of air pollution on the mental health of adolescents. And a lot of studies, they look at these associations, but they actually don't look at this descriptive statistics at all. So it's really important we know, do people live with mental disorders? Do they live in more, polluted areas, because this is going to affect your health massively. Or, are these people more vulnerable to the effects of air pollution? We don't really know, and there's just not enough evidence out there. And in terms of my PhD, I'm also hoping to do some public engagement as well. So I really want to involve adolescents. I know they're a hard to reach group, and I have been in contact and I work with adolescents in schools. So I'm really hoping to include them for, direction of the project. I want to look at making a workshop to kind of look at, do they think about mental health? Does the environment affect their mental health? And hopefully with dissemination as well. So yeah, that's it.
Perfect.
Thank you.
Thank you. Thank you. Questions for Ella? Yes, Dasha.
Hi.
I'm Cassie, I'm a postdoc at King's, and I did some research during my PhD around natural environments and young people's mental health. And I just wondered if during the study you had to think about teasing apart deprivation and pollution, because sometimes they're linked. So areas where there's maybe more deprivation on a number of different indicators, there can also be high levels of air pollution. So
Yeah. Yeah, so I didn't do that for this was just a really small project, to be honest, but I completely agree with you. This is something that a skill I'm developing, but really nice to do some geospatial maps and maybe look at higher air pollution levels and then see if they're also in more deprived areas. And this is definitely something I'll do for my PhD because it's so important when looking at these associations. But I didn't do it for this, but yes, completely agree. Really good point.
It's a similar question, I suppose. So green space as a factor with mental health. Are you able to tease out what sort of high quality green space versus low quality and your sort of nested models to explore?
I think they have done that. It's not, again, I'm very much at the start, but I know other people who've looked at well-being, adolescent well-being, and in green space, so the kind of amount of green space. I don't know if they look at a lot of I've seen is the volume, but they probably do look at quality. I'm probably not the best person to ask. I don't know yet, but I would. It's definitely something I want to.
And this is not allowed.
I guess what I'm saying is Amy Miser is looking at that.
James. No, we have time.
All right, okay. So I was going to touch on the urban environment. There's this story about urbanicity being a big risk factor for developing psychosis, and how you're going to tease that out from the. I'd imagine that is highly correlated with.
It is massively, and obviously in more urban areas there's more pollution, but no one's really disentangled which one it could be. And again, it's probably both. I would say more than anything with this sort of thing, it's going to be so many factors that come. It's very individual as well, so it's a really difficult one. I would say the idea in my head is to do some sort of regression. We're looking at that air pollution and mental health, but we're going to bring in urbanicity, deprivation, hopefully green space. So that's kind of the idea I have in my head. But yeah, I think they kind of both go hand in hand. So it's really difficult to know which one it is. But yeah, sorry, I don't know. That doesn't really answer your question. But yeah,
That's great.
there's different types of pollutants in rural areas, and you'd be surprised. It can be actually quite polluted in rural areas, but it's just different pollutants. So you'd be surprised, but that is something I would like to look at because that would be interesting in itself. But yeah.
Great. Thank you so much.
Thank you.
So our next speaker is Futini Tseliou from Cardiff University.
I'm Futini, I'm a research associate at Cardiff University, and today I'll briefly present about the work I've been doing previously with the Wizard Education Data Lab, which mainly looked at how the frequency of school exclusions varies over the pupils' life course in school. And this was part of a multidisciplinary project called Excluded Lives. We looked at exclusions across different parts of the UK using different types of methods. And I'm sure you're aware that there is like a debate on whether there is merit and need to exclude pupils from school and the impact it can have on the excluded pupil life, but they're still very common. And there have been some studies that made also the news about some pupils that are more likely to experience exclusion and then have disruptions in their education. But a lot of them are cross-sectional, and we're looking at a more dynamic approach into studying exclusions across life in school. So we aim to address this gap in using administrative data, and we chose a cohort of pupils of over 26,000 pupils in maintained schools in Wales, so that did include pupil referral units. And we had data from year 6, which is the end of primary school, to year 11, which is the end of secondary school. And I hope you can see there from the back, we had a number of different information, like gender, ethnicity, special education needs, including type of special education need, like behavioral or physical, and eligibility for free school meals, as well as other types of data on the school level, like primary language, and early level, like regional education consortia. And we'll just to bear in mind that we looked at exclusions, both fixed and permanent, because due to small numbers in the permanent exclusions. And you can see, like in the figure here, that we identified 5 trajectories in terms of variation of the frequency of exclusions across the years that we had available. And you can see the mean number of exclusions in each class across years. And of course, the bigger group is the one that didn't experience any exclusions. There is a second group that experienced a low number of exclusions in early years. A group that has a very high number of exclusion in early years. Another one is more like low exclusions in late years, and you can see the huge line of exclusions in late years. And we found that the pupils that had like behavior or mental health condition, as identified as special education needs, and those who had were consistently eligible for free school meals, were at increased risk of experiencing exclusion, particularly in early life, which can be very disruptive in their education. And this can be also seen by the fact that those that had a greater number of exclusions over time were linked, and particularly in that early group, even though it's small, they had much less achievement in GCSEs. So we can see that it had an impact on their education life. And so we know that these trajectories suggest that there are those differences that are underlying reasons leading to exclusions, and this cannot necessarily be seen in the records. So we know that they're very important in informing like policymakers, and not only local but wider in terms of addressing school exclusions.
Great, thank you.
Was I on time?
I'm a softie in the end. Do we have any questions? Anne?
Really important topic area, excellent presentation. I was just wondering if you have any thoughts about the impact of the fact that we're going to university meals, so the free school meals is going, and the fact that we've moved from SEN status to ALN status, and how that, one, might impact your findings, and two, might impact future work.
Yeah, so it's tricky. I'm using the term special education needs, even though it has changed now in Wales, because at the time of the data I was looking for is before that change. I tried to stay before the pandemic because the data got messy there, you know. There were different criteria. And yeah, it's gonna have an impact in terms of how it's defined, like even the categories that are available, and also the free school meals, again, because we saw differences even within. So, for example, those that were eligible for free school meals once or a couple of years were not as high risk as those that were like older years. So, yeah, any change in that is going to have a big change in their education and exclusions. And yeah, we know that, unfortunately.
Great. Thank you.
Thank you.
Thank you. Our next speaker will be Katrina Davis from King's College London. Ooh.
just got to afternoon, so happy afternoon, everyone. Right, I'm going to speak to you about testing a natural language processing model. So, patient data is often stuck in organisational silos. So looking at electronic health records for mental health services, such as CRIS, mental health data is fairly accessible, but getting physical health data probably means having to link to external sources. But what if the data was actually in the electronic health records, but in the free text? MedCat is a natural language processing platform that searches record text for concepts that refer to patients. The MedCat comorbidity app searches for about a dozen long-term conditions and has already been applied to the CRIS SLAM patients. My interest is in older people with dementia, but actually the methods that I present would be applicable to other patient groups as well. Now, I had a small data set of linked data between CRIS SLAM and Lambeth DataNet, which is a primary care database. And that included about a quarter of my dementia patients from CRIS SLAM. And that allowed me to compare NLP outputs from the MedCat comorbidity app with the pre-existing diagnoses that have been documented in primary care, which I extracted using publicly available code lists. I concentrated on the 6 conditions you can see here. On the far, that's right, isn't it? I've written left. Yeah, no, that is right, yeah. Okay, on the far right, you can see how many patients the NLP app identified with each condition. And when I checked back at the flags that had been left on patients' notes to check whether they were true references to the condition, most of the time they really were. And that gives you this high precision that you can see in the last column on the right. One outlier is diabetes, which gets mentioned a lot, but sometimes it's to blood tests, sometimes it's to do with medication, not actually to do with a diagnosis. So that's slightly lower precision. On this left-hand side, this is where we have the comparison with the primary care data. The length of the bar is the number of patients identified through the primary care data, and the darker portion is those that were also identified by the natural language processing. And so the percentage is what we call a recall. It's like a sensitivity. Now you can see that the recall isn't brilliant, but in research we can cope with highly specific but less sensitive data. The problem will come if you try to make this a clinical tool. Now you can see that if you are only able to identify someone's previous heart attack less than half the time, that wouldn't be great. And so what we need to do is look at ways of tuning this. For example, clinicians love acronyms, but NLP designers hate them. So if we could tune it so that this could read more of the acronyms for myocardial infarctions, which are heart attacks, then that would be brilliant. So overall, I found that my investigations were quite reassuring for my work, but I came up with some ways that maybe we could improve it going forward, and this would also mean that it would be improved for other patient groups.
Thank you. Yes, Ben.
Again, sorry. This is fantastic, and I definitely want to speak out it afterwards because we're trying to do something similar in Korea. Have you looked at all at the sort of the inverse of mental health diagnoses and as derived from the SLAM data, which is the secondary care data, which you expect to be better, and then whether you get kind of an inverse pattern for the primary care recording of those mental health diagnoses? You've just been looking at this.
Yes, so this is part of my PhD, which has become this legion that has been going on for 7 years or something. And in that, I did publish a paper comparing dementia diagnoses in primary care and secondary care, because the suspicion was that you got a different cohort if you took the primary care and secondary care. In fact, the cohorts were mostly overlapping, even though the patients didn't overlap. The characteristics were mostly overlapping, so that was reassuring. In terms of mental health diagnoses for kind of functional mental health disorders, I haven't looked at those here. Yeah.
Thank you. It was great. Thank you. Sorry, I cut the question time sometimes. Great. So the next speaker would be Margaret Diogu from Swansea University.
Okay. Hello, everyone. My name is Margaret Diogu. I'm a health data scientist with Swansea University. And I'll be giving a talk. Oh, okay. So I'll be giving a talk on suicide bereavement in household and its impacts on a child's mental health. So considering the traumatic loss of a household member to suicide and its impact on children's mental health, and when compared to children who've been bereaved of natural death or accidental death. And the lack of evidence-based research in the UK examining this impact formed the basis of our study, which was aimed to determine the long-term mental health outcome of children bereaved of suicide in the household. In doing so, we used primary and secondary healthcare data set in SAIL data bank between 2000 to 2019, and we were able to identify children between 0 to 17 years who were bereaved. And then, amongst those children, we identified 2,117 bereaved of suicide death, and 1,790 of accidental death, and 33,733 of natural death. We matched them and compared suicide to accident death and suicide to natural death. Then we'd use a Cox regression analysis with a 10 years follow-up to determine if they had anxiety, depression, self-harm, or use alcohol or drugs. And the key finding of our study, as seen in the table above, was a 22% increased risk of depression for children who were bereaved of suicide death in the household, when comparing them to children bereaved of natural death. And for time to depression, the risk factors remain being female, being deprived, the comorbidity of the child, and presence of an adult with mental health disorder, as well as increase in age. However, when we looked at suicide and accidental death in children who were bereavement, there was no significant difference. And then the limitation of the study was data collection errors, because we use electronic health record, and misclassification of diagnosis, as well as information bias on the reporting from events, and sample size as seen in accidental death. In all, our study suggests the need for tailored support, monitoring, and early intervention for children bereaved of suicide death in the household to help improve their mental health outcome during the grieving process. Thank you.
Wonderful. Great. Do we have any
questions?
Oh. You can take over. Yeah.
Thank you. That's really interesting. I was wondering whether you looked to see if there was any difference in outcome as to whether it was the mother, father, or a sibling who had died.
Okay, so we didn't look at that because the available data at the moment didn't have that. So we just looked at the a definition of household, irrespective of who it was. Yeah. So we didn't look at specifically if it were the husband, the father, the mother, or the children, siblings there. Yeah.
Great. So maybe I will ask one. You kind of mentioned that one of the limits was the data, I think. So what recommendation would you suggest for improving data for this kind of research?
Okay. So as we know, electronic health record, it's collected from the NHS, secondary primary health care data, and we're humans, right? So you've been married with human errors. People could get exhausted and not ask the right questions, you know, and not pick the right symptoms. So you'd have underreporting. So we're saying, oh, can clinicians, healthcare practitioners be better in reporting this? Right? So that's one of it. And as well as also the data scientists, when they impute that, there could be errors, right? And erroneous dates as well. So you could see dates where someone is born in 1984, and then you see diagnosis of 1900. That's impossible, right? So we're saying better diligence in reporting this data.
Great, thank you.
Thank you.
Well done. The next speaker would be Nabil Isaac. Ajali Hernandez from, Gran Canaria.
Holidays.
Yeah. Ooh.
Welcome, good morning. My name is Nabil. I am from the University of Las Palmas of Gran Canaria. And my work is titled A Cost-Effective Biometric Sensor Approach for Emotion Detections. So, emotions are a subjective construct. Understanding patients' emotions would be of great value in mental health care. So, if we were able to quantify the emotions, we probably obtain an objective point of view. It means that we have better treatment, diagnosis, management, and all of these things related to mental health care. So, there are many works that are focused on quantified emotions. One of most famous is those that are related with EEG, electroencephalogram. They wanted to measure the brain signal in order to quantify these emotions. There are another works, for example, based on imaging recognition and speech recognition. They approach on capture the signal of video, for example, and translate it to quantify the emotions too. But these approaches have certain kind of disadvantage. For example, in the everyday use. So, and in the cost, they are expensive. So, what we are proposing here is a cost-effective biometric sensor based on low-cost device for emotion detection. And how can I do this? So, we have 5 low-cost sensors that are blood flow, blood saturation, temperature, galvanic skin response, and airflow. And with these 5 low-cost sensors connected to an Arduino board and connected to a Livelium eHealth board, we use machine learning to predict the emotions. So we've recorded a 14 people data set, and what we found is that we are able to classify emotion of fear and disgust with a 94% of accuracy. It means that with this device that only costs approximately 20 pounds, we are able to classify the emotions better than the other works, and not only in terms of accuracy, but also in terms of cost, in time, and in infrastructure. So we think with this accuracy and this cost that our system is a proof of concept that is able to improve mental health medicine and all of this field, and it could have a big impact in mental health, deep in phenotyping research and precision medicine. So we think that here we potentially have a cost-effective tool to have a real application in this field. Thank you.
Thank you.
Time for questions.
Thank you. Do we have any questions? Yes, Katrina.
Hi, I wondered whether this would have any application in people who would find it difficult to explain emotions, so non-verbal people or people with autism. Have you looked into whether it could be helpful in those situations?
I think that these kind of approaches based on EEG are better than our, because we are focused on physiological signals. So maybe people with this kind of disorders have the same signals or not. It depends of the case. So I think that focus on brain signal is better than in this case. Yes?
I was wondering if you can, with this, kind of looking at the biobehavioral indicators of stress, if you can look like heart rate variability with the blood pressure, and they're even getting things like cortisol measurement with skin now. Is that something you think you could develop, where you look at not just emotions, but also people's stress response with this?
In our study, we choose these 5 sensors because they have correlation with the emotions, but we try to use like 20 sensors, but the most relevant was this, or this. I don't know if I answer your question. I don't know.
So just with the blood flow, could you get heart rate variability?
Mm-hmm. You have the pulse with a infrared sensor, no? And it's a variable that allow us to measure better with machine learning, because machine learning is based on no linear relationships. So what said Marcos yesterday is that this kind of variables, we must to analyze what is behind these results. It's not only the result, it's what is behind the results. Thank you.
Thank you. Now, the next speaker will be from ECR Health, and that would be Panagiota Kontari.
So, hi everyone, I'm Panagiota Kontari and I'm a research scientist at ECR Health. Thank you for the opportunity to present our preliminary results on the association between psychiatric multimorbidity and dementia risk over 23 years using ECR Health secondary mental health care data. So there's quite a lot of evidence to suggest that psychiatric disorders are associated with cognitive impairment. Further, in adulthood, psychiatric disorders have been found to independently increase dementia risk later in life. But what we don't know to date is the impact of psychiatric multimorbidity on what is the co-occurrence of 2 or more psychiatric disorders on the risk of developing dementia. So for the aim of this study, we want to see if patients with psychiatric multimorbidity are at higher risk of developing dementia compared to those having a single disorder of either anxiety, major depressive disorder, bipolar disorder, and schizophrenia. So in methods, we use the ECR Health's data, which has about 4.6 million patients. We have like anonymized electronic health records in the UK. From this, we identified 118,271 patients diagnosed with psychiatric disorders who met our study criteria. So patients were included if they had recorded diagnosis between 2000 and 2024, who were aged 40 years or older at their first recording of diagnosis, and remained dementia-free for 2 years post-diagnosis. And these patients were grouped based on their diagnosis, with anxiety disorder as the reference group, and those with more than one diagnosis were grouped, classified into a separate multimorbidity category. And for statistical analysis, we ran Cox regression to estimate hazard ratios for the association between patient groups and dementia incidence, and we also adjusted for age, gender, and ethnicity. In our results now, a total of 12,628 patients, about 11% of our sample, developed dementia during the follow-up. And as you can see on Kaplan-Meier survival curves, our key finding was that psychiatric multimorbidity was associated with the highest risk of dementia, differing substantially relative to the other groups. Similarly, Cox regression showed that patients with multimorbidity were 2.5 more likely to develop dementia compared to anxiety only. In conclusion, using Crivia electronic health records data, this study showed for the first time that psychiatric multimorbidity increases significantly a person's risk of developing dementia compared to having a single diagnosis of psychiatric disorders. Yeah, of course, more research is needed, but we can highlight that this highlights the importance of early identification and tailored interventions for those at risk of psychiatric multimorbidity. Thank you very much.
Thank you. Questions?
Hi, this is really interesting, but I just wanted to dig down further into what you mean by psychiatric comorbidity, because different diagnoses appearing in the notes at different times could be quite different from things co-occurring. So he has schizophrenia and an anxiety disorder. So I wondered whether by comorbidity you mean at the same time, or whether you mean more than one diagnosis in the whole notes. And if it's the second, how is that related to the volume of notes? If you're going to see a secondary care every week, you're more likely to pick up more diagnoses. So I wonder whether you thought about things, kind of dug down into what comorbidity actually is.
Yeah, good point. Yeah, for this study, just we used clinical notes and electronic health records, and we saw if like one patient had more than one diagnosis of these specific severe illnesses in their records over time. So it's more like, yeah.
They had longer records.
Yes. Exactly, yeah, maybe just anxiety that came first, and then like depressive symptoms or like schizophrenia came later. But that's interesting, and as part of our next steps is just to see, to further explore the synergistic effects of co-occurring psychiatric disorders and see, for example, like which clusters or patterns of comorbidities are most predictive of dementia.
Thank you.
Thank you very much.
Our last speaker is Tom Metherell from UCL.
Thank you, and I'm well aware that I'm now the final thing standing between you and lunch, so I'm going to try and keep it brief. So, yeah, my name is Tom Metherell. I am a PhD student at the Centre for Longitudinal Studies at UCL. Now, I've been asked to focus on one very specific part of this study, so I am not going to talk about my results or the discussion or part of the methods. If you're interested in any of these things, you can either talk to me at lunchtime, or if you don't want to talk to me, you can look at the QR code instead, and that will tell you everything you want to know, hopefully. So sleep and mental health are two things that we know are related to each other in a variety of ways, but what we didn't have, we found a gap in the literature in terms of the relationship between mental health early in life, in childhood, and sleep duration later in life, so in this case in midlife. So we wanted to investigate this using the 1970 British cohort study because, we want to keep it in the family, it's our study. And so we have these data that were collected at age 46, which was a kind of biomedical sweep of the study, including, so around 8,000 participants who were still participating at the time were issued with an accelerometer, which is this lovely orange device that you see here, which was strapped to their thighs for a period of a week. And we could use that to monitor their physical activity during that time. And by extension, we could perhaps infer when they were asleep, by when they were not moving that much. Okay, people move around in their sleep, but we can use a variety of algorithms to kind of derive potential estimates of sleep duration from the accelerometry data that we had collected from these participants. so we have 3 different algorithms that we ended up using. So we had 3 different measures of sleep that were a little bit more objective than the self-report measures because we were worried that the self-report measure might be a little bit biased or whatever. Also, we had a 5th measure of sleep duration as well from sleep diaries that the participants filled in at the same time. So then we had 5 different measures of sleep that I could relate. Then we've identified 7 different measures of mental health in childhood, for which I was totally reliant on Louise's catalogue of mental health measures. So thank you for that. So then we had 35 different regression models to fit, which took quite a long time. But I'm not talking about the results. I'm only talking about the accelerometry data. So what we ended up finding was that there was actually quite a poor correlation among our different measures of sleep. There are many possible reasons for this. One of this is that the accelerometer was worn on the thigh, which makes it difficult to tell somebody is sitting down or lying down. So that means we have to adopt a range of heuristics to try and work out whether someone is actually just lying down asleep or whether they were just sitting down for a really long time. And one of those heuristics would be, for example, was it at night? So then it kind of biases against people who have night shifts and things like that and are sleeping during the day. We found some algorithms tended to overestimate because of what heuristic was used, some tended to underestimate. However, when we combine those with the self-report measures, we actually found very similar results, at least with one of the algorithms and the self-report, and also the slightly more objective self-report from the sleep diaries. So we have slightly more confidence in the results that we ended up finding by combining these different measures together and just kind of triangulating what we thought would be the ground truth. So my kind of conclusion from this part, not from the actual results, is that you can do it. There's still a little bit of work that can be done in improving the algorithms, and there are some more complicated algorithms that you could maybe use. It's just that I thought my computer might explode if I tried it, so that in the future, and if someone has a better computer than me, they can try it. So it's possible to do, and it's a great way of kind of triangulating results if you don't have that much confidence in your self-report measures. And please use these data because they've been sitting around in a server in UCL for 8 years and nobody's used them until I got there. So please use them.
Thank you. Would you say that you have a gold standard? Is there a gold standard measure amongst all of those?
Not among these that we used because we had so many participants. It's really expensive. So the gold standard would be to do polysomnography, where someone is strapped into machines and stuff all night. But that's obviously completely infeasible in a study of this size. So there's 17,000 participants in the BCS-70. But on the other hand, we do have papers that have validated these algorithms against polysomnography and found that it was an acceptable estimate. So we can kind of go, okay, it was all right. It's not perfect, obviously, but it's something. It's definitely something.
Yes. Hi, I just wanted to ask some questions about the poor correlation among estimates between the algorithms. What were the algorithms and why do you think two of them tend to overestimate and one tend to underestimate?
It's kind of complicated. The algorithms. So one of them, I have no idea what it does. First of all, because it was proprietary, and the company refused to specify what it was. It was the company that supplied the machines, and they just gave us some sleep estimate and said, "Here you go." And I said, "What? How did you calculate this?" No idea. So I don't know about that one. There's one that I think probably overestimated because it kind of counted too many instances where people were in bed but not asleep, because it's impossible to tell when someone falls asleep if they're just lying down from the thigh one accelerometry data. And then one tends to be a little bit too conservative and was relying on really long periods when actually that might not be realistic in terms of when people sleep, because they might be waking up a lot during the night. So I think based on the kind of ways they tried to get around the challenge of the thigh-worn data, they ended up with different problems in terms of biases. But as I say, there are more advanced algorithms that you could use if you had a few months to run the analysis, and that might lead to better, more reliable results. But it's just so many participants that we had to kind of keep it as simple as possible.
Thank you so much. That's the end. That's the end of the early career researchers presentation. So please, great congratulations to everybody. It's a great achievement and very entertaining session as well for us. Just to let you know that if you don't have a badge, please collect your badge at registration at the back over there, just so that we all know who we are and all that stuff. We're slightly late, only 10 minutes, but now it's the lunch, so you can grab a sandwich on the other side, and it will be the poster session as well, so please come back, drink sandwiches, and please hang around and discuss research with those people who presented poster and our wonderful early career researchers who just presented.